Welcome everyone. Just going to give everybody a minute or so just to come across from the other talks and to join us. Please do write where you're from tonight. Do say hello. Welcome everyone. Just going to give everyone a few seconds just to join us, then we'll get started. Please do let us know where you're from. Say hello.
And if it's mad hot.
Yes, thank you for joining us on this very, very warm evening. We do appreciate you being here. Fantastic. Please say hello. Let us know where you're tuning in from this evening. You've enjoyed the first session. Sunny Swindon from Dublin. Hello, Nicola, Susanna. Good evening. Hi, Claire. Hi, Heather. From Malta. Lovely. Actually, it's probably a lot warmer than here. So Hi, guys. Brilliant. Thank you for joining this evening. Welcome to the Lower Limb Masterclass. And again, I hope you enjoyed everything so far. We have the wonderful Jack March with us this evening, who is the rheumatology physio, and he'll be discussing lots of rheumatological case studies with us and focusing on lower limb masqueraders. Please do ask lots of questions for Jack in the Q&A box. I will give you prompts throughout just to think of some things and ask us at the end, and we can go through them all. So let's get started and enjoy the session.
Thanks, Charlotte. Hi, everybody. A little admission from me. I've had this pun of Rheum, Forest Rheum for ages and been waiting for an excuse to roll it out. So here we are. We have managed to roll out the pun. There's really nothing to do with this presentation at all, but I enjoyed that. If you particularly enjoy wordplay, there's not much more of it. You don't put up with it. But what we are going to do is I've got 3 case studies for you in this presentation, and the idea is to illustrate to illustrate the complexity of recognizing rheumatology in musculoskeletal practice. A little bit to sort of say what the signs and symptoms of some of these masqueraders are. Just, that's included in there, and just to also try to help you with how I process some of these things with my, how I reason through some of these cases. So these are real cases from my history of musculoskeletal practice and rheumatology, and we'll talk about them, and hopefully it will sort of become clear as we go through what we're trying to do here. So as I mentioned, this is complex. I start with this slide in almost every presentation I do. The rheumatological conditions, this doesn't cover all of them. This covers the majority that cause obvious musculoskeletal manifestations. But even down to conditions like osteoarthritis and gout, the crystal arthropathies, they cause low-grade or high-grade synovitis, which is the main sort of symptom driver in rheumatoid arthritis. If you look at the connective tissue disorders like lupus, scleroderma, mixed connective tissue disorder, their primary musculoskeletal manifestation would be synovitis, and very similar looking to rheumatoid arthritis. In polymyalgia rheumatica, about 25% of patients with polymyalgia rheumatica have peripheral synovitis that looks a lot like rheumatoid. So even when you get down to thinking some of these things are rheumatological, then you can still get it wrong from a differential diagnosis point of view. It's definitely a good idea to be getting some assistance with that, but obviously that is also what rheumatologists are for, and hopefully you should be able to access rheumatologists in your locality or in your teams. Hopefully would be ideal, but hopefully they will be available to you. Obviously the real world doesn't always make its way as easily as that, but let's see how we get on. So what you'll notice, another admission from me, you'll